housekeeping issues. I wanted to let you know that all of you have joined the webinar today in listen-only mode, so you don't have to worry about muting your mics. That's been done for you. And I'd also like to tell you that the webinar is being recorded, so you'll have the opportunity to rewatch the session afterwards and share it with others, and we hope that you do. And I'm going to be sending out to all of you after the webinar a link to where you can get the recording and also where you can download the slides. We have a few slides, not a lot of them today, but you'll be able to download them there. Also, during the webinar, we want to hear from you, so please submit your questions anytime. You don't have to wait till the Q&A session. So you can submit those questions to our presenters using your attendee control panel. There's a little questions module there where you can submit the questions, and we'll get to as many of those as we possibly can during the time we have allocated. If we're not able to get to yours today, just know that we will follow up and make sure we do that via email afterwards. So, all right, without further ado, our presenters today are Dr. Christine Caulfield, CEO of LSF Health Systems, and also Dr. Candace Hodgkins, who's the president and CEO of Gateway Community Services. And moderating our discussion is Mr. Jack Diamond, who's the CEO of Brennan, Manna and Diamond LLC. And before I hand it over to Jack, a couple fun facts about him, and he's going to tell you more about Drs. Caulfield and Hodgkins, but a couple things about Jack. Jack is based in Akron, Ohio, and he is listed in the best lawyers of America. He has been selected as one of the top rated lawyers in healthcare and is co-founder of the American Bar Association's Health Law section. And Jack also likes to ski and hike with his children and his grandchildren. So at this time, I'm going to turn it over to you, Jack. Welcome.
Thanks, Garrett. I hope everyone can hear me. And thank you for the opportunity to discuss this important topic.
Loud and clear.
It's this is a privilege to be able to have this distinguished panel speaking about the success in managing people with serious mental illness. I know how important this issue is, and of course, substance abuse is always part of that. With what I do, I'm a healthcare lawyer, and speaking to our ACOs and other clients, I know that dealing with this particularly difficult population to manage is always an issue that comes up. And we welcome any ideas that help to address these issues. And I think that I'm looking forward to discussing these issues and bringing it out. Let me start with Dr. Caulfield, who's our first speaker. And I've known Christine for a long time. She's with Lutheran Services of Florida, the health system, and it really is a great privilege. I can't think of anyone I've ever worked with in behavioral health who has the ability to solve problems like you do, Christine, and thanks for letting me be involved in this. Your clinical expertise in substance abuse, trauma recovery, grief and loss, and integrating problems with the elderly, which you and I have worked with, is incredible. One of the things that we got to do that Garrett mentioned is we shared personal issues and or personal, I guess, backgrounds. I've known Christine forever. I know she likes to travel, and this whole COVID-19 is probably driving her crazy. And one of the places that she wants to go to, and her last visit was to Italy before this all hit. So that was fun to learn about. And as we move forward, I guess what I'll do is a little bit, I want to discuss our second person. So we've got Dr. Hodgkins, and Candace is with Gateway Community Services. And Dr. Hodgkins, some of the personal things we found about you is that I know that you are the CEO, and this is one of the agencies which LSF deals with, but I was really pleased to find about your grandchildren who are in Colorado and Florida, and how you get to see some of them. And also an interesting fact about you is that you are a ballroom dancer. So that was incredible to learn. So we keep going on, sort of to get this going. We'd like to start on is, let's start talking about care coordination. And Dr. C, can I start with you and just dive into this discussion? Can you tell us a little bit about Lutheran Services of Florida and your care coordination program? Because I think it's very unique and you've got some real good insight in that.
Absolutely, Jack, and it's such a pleasure to connect with you again. He truly is the top attorney in the country, in my humble opinion. So Thanks, Jack. We are a managing entity here, LSF Health Systems. And for those of you that aren't familiar with what a managing entity is, we are responsible for the funding and the oversight, and also creating a network of stellar behavioral healthcare organizations that span our 23 county region here in Florida, which that's about a third of the state. And what we're responsible for is serving those individuals that are indigent, uninsured, or underinsured in the state of Florida that live with mental health and/or substance use disorders. And what we found is that we certainly have very complex individuals that we serve. Not only do they have complex psychiatric needs, but they also oftentimes have complex comorbid medical conditions. And so we always look at our clients holistically. We serve about 300,000 through our network of care a year. And we want to ensure that we are treating the whole person. We also find that our high utilizers in our system of care, those that go in and out of jails, emergency rooms, crisis stabilization units, really are driving up costs. And it also tells us that we're needing to look closer at these high utilizers to see where are the gaps in services that are needed to wrap our arms around them so that we can reduce cost, we can get them the help that they need, and we don't see that high recidivism rate into these high-end acute care services. And we have also seen that care coordination is the key in doing this. And so we created a care coordination division here at LSF Health Systems. And it really demands that you, A, are expert in the field of behavioral health care, B, that you have service providers that you know are the best of the best, and that are providing best practice protocols and getting very good treatment outcomes, and that you also have relationships with all other stakeholders, important stakeholders in your community, such as sheriffs, law enforcement officers, the court system, the hospital administrators, and the ER docs, and EMS, and all those individuals that touch the clients that we are serving. And all of us are interested in making sure that these individuals stay stable, they stay medication compliant, they frequent their PCP offices, their primary care physicians, their healthcare providers, and not use the emergency room as their primary care stop. And so with all of that combined, what we do is with our care coordinators is we enroll our high utilizers in our system of care. We wrap our arms around them in conjunction with our providers. And again, the best of the best, ensuring that we review treatment plans, that we ensure that the client is visiting their PCP as prescribed, that they're aligning with their treatment protocols and their treatment plan goals, and that they are remaining stable and out of the high-end acute care system. This program has proved to be extremely successful. And here in the state of Florida, we have Medicaid managed care plans, and their average recidivism rate for their high utilizers is around 22 to 24%. And we have been able to accomplish a 3 to 5% recidivism rate. Again, with our care coordination division and working with those providers that are in our network that we have carefully vetted and know that they're offering the best care. And we've been able to be very successful with this. And I just want to share a little bit about our providers. Not only do our providers in our network receive funding from us as the managing entity, those state funds for those indigent, uninsured, and underinsured individuals, but they also are on a variety of other insurance panels, Medicaid, Medicare, Blue Cross Blue Shield, and others. So they have a full array of offerings, not only just for indigent clients that we are responsible for, but clients in general in the community. And we have had just such a wonderful success that our managed care companies are coming to us and saying, how are you doing this? And what is the secret sauce? And how can you help us? And so we decided at LSF Health Systems that, we have a product that not only is working for us with the highest utilizers in our system, the individuals that have severe and persistent mental illness that go in and out of these acute care, high cost service settings, but we have a product that can be generalized to ACOs, to managed care organizations, and others that are struggling to keep their costs down. They're struggling with knowing how to treat these individuals with severe and persistent mental illness. We help them intervene early. We help them with prevention and early intervention. We help them with integrated health care so that we can ensure that their clients remain stable and they can enjoy a better bottom line as a result. So we just are real proud of the program and very glad to be able to present on this seminar today.
Christina, in preparation for this program, I know we were talking about different issues that come up and problems. And, from the legal perspective, I told you that one of the things that we often hear is the problem in coordinating the clinical issues with the behavioral health issues. And one of the problems is that the physicians, especially the primary care doctors, feel they just can't get information, and that the behavioral health side or the hospitals often are saying it's a HIPAA problem, I can't talk to you, and they're overrushed, and then or patients get lost in the system. And I know you do a very good job dealing with getting the right information to the primary care doctors so you get a coordinated care approach. And that's a great deal of a great, I guess, basis for frustration I've heard from our clients. Can you discuss that at all?
Absolutely, and we're very fortunate to work with InfoMC, and that is our partner that collects all the data, manages our care coordination through just a state-of-the-art module, and that involves the communication channels, ensuring that clients don't fall through the cracks, that they have the warm handoffs, that the primary care physician offices are communicated with frequently, because it takes a village, if you will. It takes everybody working together to ensure that these clients don't get lost in the shuffle and don't have the opportunity to decompensate and need those high-end services. And again, the partner that we are utilizing and have had great success with is InfoMC, and that's one of their main tools is their communication connectivity, and we find that to be very, very successful.
No, and thank you, because I think that is, I know you do a great job addressing that, and those numbers are incredible as far as the recidivism. And I think it's because you realize you can't do it alone. Nobody can do it alone. You need all the team players who are helping get the right results. So that's incredible. We'll move on to Dr. Hodgkins. And Dr. Hodgkins, I know that you're a mental health counselor, but you also have an expertise both in mental health and substance abuse disorders. And I know the substance abuse can't be ignored in these conversations. It always comes up. And I think that being able to work with LSF, which you do a great job on, you've had some good results. Can you talk a little bit about Gateway and how you integrate with LSF?
Sure. And let me first say thank you so much for asking me to be here today and to share the stage with Dr. Popfield. She is LSF in our area, and she is our partner. And so that's how we work so well together to create a wonderful platform for patients to get what they need in our community. So Gateway has been around for 40 some odd years. Started out as a grassroots substance abuse treatment center by influential men who were alcoholic and came back and said, gee whiz, what do people do that don't have money? And it's grown from there to a over $20 million organization that has detox all the way through residential outpatient, all the way to recovery housing. We treat adolescents and adults, and we also provide an early learning center so patients can come into treatment with their children while going through treatment and not have to be separated from them. I think since this is the topic of care coordination, how we work with LSF as a partner in that is that their care coordination team works with our care coordinators who are in our detox facility on individuals who, as Dr. Caulfield presented, are high utilizers and cost the system, so to speak, for the state a lot of money because they keep rotating in and out of services. And so we've been able to reduce that tremendously by having the LSF team come and meet with our team on a regular basis, identify the individuals, and brainstorm about what we can do to help them continue not to come into our services, which with an addiction is very difficult a lot of times. Yeah. Also, the benefit of that is that LSF and Dr. Caulfield have such a wide catchment area of providers that if something's not working at my organization, they are right there to help find another organization in our catchment area that could provide services to an individual, because not one shoe fits all, and it's really about a holistic process, as Dr. Caulfield said, and how you work with everybody to find the best fit, because not every shoe fits every foot. So the other way that Dr. Caulfield has helped Gateway is that our community, back when the opioid crisis hit in 2016, and we came together as a group of stakeholders, which was facilitated by one of our city council people who said, we have a big problem in Duval County, and what are we going to do about it? And challenges us all to come up with some sort of plan of how we're going to address it. And so with Dr. Caulfield's help and my chief medical officer and other stakeholders such as Jacksonville Fire and Rescue, the doctors from the morgue who were feeling overwhelmed with how many people were dying, and hospitals in our community, we came up with a plan called Project Save Lives. And it started in November of 2017. And it really is based on care coordination. What it is that you have peers in the ED assigned to different EDs in town. And when somebody comes into the emergency room, and it started out just to address the opioid overdoses, but it's expanded now to address co-occurring disorders and mental health disorders also, and other substance use disorders. The peer meets with the patient, is introduced by the doctor, and if the patient consents to services, then the peer helps that individual go from the emergency room without their feet touching the street. That was a comment from my chief medical officer. Treat before their feet hit the street, and actually do a warm handoff to either us at Gateway or some other provider in the community that can provide services to what the needs are of the individual. And it's been wildly successful because a peer specialist has a lived experience, and somehow they can speak the language to the individual. One of my staff says it's the language of the heart. And the person in the ED understands that. Now, these are people that did not come into the emergency room and say, oh, I want to get into treatment. Yeah. No, that's not why they were there. So the peer helps facilitate the beginning process. They stay with the person for 90 days. If they want to go into treatment right away, They are taken to the treatment facilities so they don't have to go home and think about it. And some of them only do peer services and never go into a traditional treatment modality. Or after a couple months, they say, oh, I do need a higher level of services. But what this has done is saved our community providers, the hospitals, JFRD, so much money because the recidivism rate has gone down tremendously.
It's amazing.
Yeah, so care coordination and having a partner like LSF to be able to kind of manage the global aspect of everything and know that they're in your corner when you need help is very productive and beneficial, effective, and it helps us retain our patients and getting them to be productive citizens back in the community.
Thanks, Dr. Hodgkins. I appreciate it. Let's move on a little bit and talk about data and measurement of success. Sorry, I got a little background, but Dr. C, I know that in the end, it all comes down to what are the results, and it's clear that LSF is focused on measuring success. You've got incredible results. That is especially important to the commercial market. So when you talk about ACOs and the MA, the Medicare Advantage plans, they really want to see what you've done. Can you tell us all about what you do in regard to measuring success and what data you look at?
Absolutely. Well, we really want to focus, number one, on the client and the client that has been identified in our case as a high utilizer. And we really examine, with our wonderful providers, Gateway being really the premier here in Jacksonville, and Dr. Hodgkins. But we work together, and we see, we take a deep dive into what the client's history is, what has been provided thus far, what may be some stones that have not been overturned yet, whether it be on a physical health care plane or a psychiatric situation. And we quickly, I know I keep saying wrap our arms around them, but indeed we do, with any services that we feel may be needed that have not been provided thus far, or we determine what is going on. Is it a transportation issue that this client has not been able to go to their primary care physician or their psychiatrist? Is it a housing issue that they are at risk of eviction, or they are at risk of homelessness, and they can't really concentrate on their treatment plan because they're worried about where they're going to sleep tonight? So we really do a deep dive into the social determinants of health. And I know I mentioned housing. Housing is healthcare, and oftentimes these questions are not asked in a doctor's office. Are you at risk for homelessness? I mean,
Right.
Our physical healthcare providers are looking at the presenting problem and looking for ways to cure. And so when you take a more holistic or broader approach and really dig deep, you find what is causing this individual to not be compliant. And then when you realize what those issues are, then you set a plan to quickly intervene so that they are not, again, decompensating and ending up in more acute care services. And our partner, FOMC, again, couldn't do it without them, with our care coordination module, all their communication networks and abilities to communicate with all of our partners that are treating this individual. That's key and critical as well.
Since we're in the middle of this pandemic, I don't know if you want to mention anything about particular problems that you've had as far as using telehealth or getting access to the resources you need, but anything else you want to comment on that's affected your outcomes?
Absolutely, and I couldn't be prouder of our provider network, because this pandemic obviously with social isolation and the lockdown and inability for patients to come in person, our provider network quickly pivoted to telehealth. And what we found, a lot of lessons learned, is that we thought, well, gee, will the patients really embrace this? Will they get the help that they need? Will they be able to figure it out? We have found that the clients are just really enjoying this. It has really cut down on any barriers that they may have faced in the past, transportation barriers, childcare issues that prevented them from being able to come in for appointments. And basically our no-show rates have gone down to practically zero. So especially our rural communities where there's always challenges, it's been very successful.
No, and I know that the issues and problems that you deal with are unique. They are the most complex. We've got a complex health system, and trying to work through that is really what you're just able to focus on, getting results with what resources you have. And what I've heard is that the providers that you're working with just feel they're part of that, and they get the results, and they get they control the cost in a better way. You can't have a discussion in this area without talking about social determinants of health, both for Dr. Hodgkins and for Dr. Caulfield. And I guess for our sort of last major issue, can we talk a little bit about that, especially in this pandemic time, and just as you were just talking about the barriers, just the problems and extra strain that's putting on everyone. Can you talk a little bit, start with you, Dr. C, talk a little bit about the social determinants of health and how that's impacting your work?
Yes, it's so important in your intake evaluation to include some questions that focus on social determinants of health, because we find that when those issues, let's say of housing, are not being met, that is going to greatly impact the person's ability to remain compliant, and it's really going to drive the cost up. And I know Dr. Hodgkins has other examples as well that she's been dealing with at Gateway regarding the social determinants of health. I wonder if you could speak.
Sure. Well, if you look at Maslow's hierarchy, basic needs are important to all of us as human beings. So having a roof over our head, food on the table, it's hard to have a life of recovery without having those basic needs met. And oftentimes the primary care providers, that's not their job. Their job is to diagnose somebody who has a physical ailment, and it's not their job to find them a house and make sure they have food, or even ask the questions, because then they have to figure it out for them. But that's what we do in behavioral health, that is our job. And so having partners across hospitals and primary care physicians and OBGYNs, is important, because that's what we do. And so what we've done at Gateway is created a lot of recovery housing for our folks that's transitional, so that when they get out of residential, they can go into transitional housing, and they can build back up their wealth in how to manage their lives. There's so many things that people who have difficulties with mental health issues and addiction issues have lost the ability to really function in the world, and they didn't ask to have that happen. It's just a function of what has happened to them over the years. And it's really important to remember that you can cure the addiction, but if you don't help in the other social determinants of people's lives, the likelihood of them staying in recovery or taking their medication because they have a mental illness and staying on it are likely not to happen. So what we do is really focus on that. We have, because of LSF, who's a great partner, they have all these spokes out in the world that they can tap into to help us find what's the best solution for our patients. And really and truly, when people come back that have gone through Gateway and they talk about how grateful they are and how much your life is improved. It's all about you helped me become a better parent. You helped me learn how to do a budget. You helped me find my first place to live because I was able to have a deposit for the rent. All of that. And some of these people, don't get me wrong, are not homeless people. These are people that are, had good jobs. They were nurses, they were doctors, they were lawyers, they were accountants. And their addiction and their mental illness took over where they lost all of that. And so they had to start over. So even those that, are higher functioning, we think, oh, well, they have a job, they have insurance, they're good. We have a lot of those people walk through our doors that they are functioning in the world to the world's viewpoint, but they're not really functioning. They're just barely hanging on by their fingertips. And COVID especially has just turned everything upside down. And how to provide good services while pivoting to telehealth, having to get equipment. Christine was a lifesaver in that. I don't know how many times I talked to her and her staff during COVID going, can I do this? Because I don't have this. Yes, go do it. Just make sure you're taking care of the patients, which is our goal. So we were able to do that. And Christine's right. Telehealth has been a benefit. I'm sure it will be here forever, I hope. We've had to look at state and federal restrictions that were lifted because of COVID and hoping that they will stay in place now and not go away. But it's not for everybody, but it is another tool for us to help individuals. And partnering with the hospitals through Project Save Lives, has helped physicians not be so jaded and worn out because they now have somebody in the ED who's going to help them with these people. And the people are grateful, and it's just an all-around good thing. Care coordination. There are barriers, like you mentioned, Jack, about confidentiality and patient rights. And so, we still have to get the patient to sign a consent form. So not everybody wants to do that. And so you help those that are willing to be helped. And you do the best you can in the community by setting up things prior, like BAAs for HIPAA, or where you can talk to hospital provider or a primary care physician that you have a BAA with. So there's ways to make it work better, and LSF has certainly been helpful in that arena.
Well, you both are experts. I know that it's hard to overstate how difficult some of these individual problems can be with patients. And Christine, when I think of the size of your organization, I mean, $150 million, 60 provider organizations that you manage, it's amazing just how much you do, but you really need experts in this area. And, I think of, and maybe for both of you, for our last issue before we open up to questions, talk a little bit about, the when I see it is, you get Baker Act issues and patients just being left to find their way. And when I look at, we'll start Dr. Hotchkiss, maybe you can start talking a little bit about your peer program, how long you've got people embedded in the emergency department who are there, for long hours of the day to be ready to respond, and how that works. And then when you see those results come back, for Dr. Caulfield, talk about that, because these are resources that I think that a lot of the ACOs and commercial, they don't understand that's out there. Talk a little bit about, how you're there when there's a problem that presents the emergency department, because we hear these problems, Baker Act, and people sometimes having to get lost in the system because they don't know how to deal with those issues. Describe that a little bit more, because I think that's really important.
So in the emergency room, even though in Florida we have Baker Act facilities, but some people come into the ED who then need to be Baker Acted once they're diagnosed and their issues, and so have been presented. So with peers, the peer is embedded in the ED. They're part of the emergency department team. And so they work together with the physician and with the nurses to help decide who has a substance use issue, a mental health issue, what is it they need. If they need to be Baker Acted, they work as a liaison with hospital staff that are the mental health staff to then create having a Baker Act. done. They work with the families of people that come in. So if they have an overdose, then they're teaching them about Narcan, passing out Narcan to them. They're there as an extension of the hospital staff in a different way. So they're really the social determinant person who knows about all the other issues that are going on in these people's lives because they've been there, done that. You know, they lived that life, and now they're in recovery and they're now taking classes and becoming certified as peer specialists. And the physicians that I've talked to, we're in 6 emergency departments now, ready to go into a 7th. And that's with the help of LSF and the city of Jacksonville have provided funding for that. And the hospitals also pay for one of the lead peers. It's just a great partnership. It's how healthcare should work. We're all working together to get the best for the individual that we are touching their lives when they're in the hospital. It reduces the stress for the staff. During COVID, which my staff are heroes as far as I'm concerned, they would not leave the ED room. We said, you don't have to go into the hospitals if you don't want to. We'll figure something else out. Oh, no, we want to be there. And they were there. And as one hospital administrator said to me, while everybody else thought that we had leprosy and were not going to come into the emergency department, your folks were there. Not only did that mean so much to the patients, but it meant so much to the staff, because the staff, as you know, in emergency departments are oftentimes having compassion fatigue on a regular basis, and COVID just enhanced that. So, I just think the peer, and it doesn't have to be just for state-funded sources. We have, a lot of insurance folks that we deal with too, and a lot of insurance folks come into the EDs. Some EDs it's higher than others, but it's usually about 50% of the people have insurance that are coming into the EDs on a regular basis for services. So I think care coordination, and if we can get it so we can loosen some of the 42 CFR stuff, all the confidentiality in a way that the patient feels safe too, and they're protected. It's a good system.
Anything else you'd add to that, Dr. Caulfield?
No, I just want to emphasize that Dr. Hodgkins stated, really care coordination has exceeded all of our expectations, frankly, and we've learned so much. And we also know that you really need the expertise of behavioral health care professionals, as well as we need the expertise of our medical teams, our PCPs, our ER docs and nurses and so on, that it takes both disciplines to really provide optimal care to individuals. Because if you're not addressing their mental health needs, their physical health care is going to deteriorate, and vice versa. So it's just a wonderful way for all of us to work together with the goal of keeping our clients stable, out of high-end services, and getting them the wraparound services that they need to be able to do that.
No, this is great. And to wrap up this discussion and open it up for questions, what I'm hearing is that it is possible to have great success in dealing with these patients. They have complex issues. They're falling through the cracks. It's an expensive problem. So anybody who's taking risk, these patients take an inordinate amount of resources and cost a lot, but you really can have success. And there's a few keys. 1, strong coordination program. 2, you've got to have a great relationship with providers, and you got to make certain you bring in the clinical care to balance the behavioral health or the substance abuse. And lastly, this isn't an area that you can dabble in. You really have to have expertise, and there's a need for it. But if you get the right experts who are willing to cooperate with the rest of the team, you're going to have great results. All right, with that, Garrett, I'm going to turn it over to you for questions and answers. All right, and greater discussion. Are you there?
All right, guys. Well, that was a great discussion, and I know I got a lot out of it. And we did have a number of questions roll in, so in no particular order, and some of them are addressed to individuals, and some are more open. Beginning with Dr. Caulfield, how long do patients stay connected to your care coordination program, and how do you know when they're ready to move on?
That's a great question. Typically, they're with us about 6 months. Some need more care and remain longer. We don't discharge if we don't think someone is not ready, but we want to ensure that they are following their treatment plan. They've got a good 6 months under their belt. They're remaining medication compliant. And then when they are discharged, they are discharged with, again, wraparound services, whether that is outpatient services at Dr. Hodgkin's Gateway, or they are assigned a case manager at Gateway or one of our other providers. So whatever they need to continue to remain stable and ensure that they're meeting their treatment goals, that's what we do.
Great. All right. Next question that came in is, and this is for Dr. Caulfield and Dr. Hodgkins. I'm interested from hearing from both of you about your view on the new digital health tools that are available, either from a therapeutic standpoint or engagement standpoint. What are your thoughts?
Well, my thoughts are digital is here to stay. As our population grows younger, if you don't know how to provide services to them in a digital way, they're never going to engage in the service. The apps that are out, some of them are very, very helpful. I think one of the disadvantages is just for our safety net population is not everybody has digital access. So they don't have Wi-Fi, they don't have a phone, they don't have a computer. So that can be difficult, as we saw, especially during COVID, but you find different ways to address that. I think as a provider, I like to be very careful about what app I suggest that patients use for recovery, because not all of them are really good. But the ones that are very, very beneficial, because what they do is the individual has somebody they can go to on the app that, it could be a chat, it could be, you can do AANA meetings on an app digitally. That saved us during COVID. We could not have anybody come in to provide meetings, so we did Zoom meetings in AANA and interacting with people's sponsors, because isolation for this population is detrimental to their recovery process. So I think they're really beneficial. Not everybody likes them, but that's okay. It's another tool that can be helpful to those that are engaged in the digital movement. Dr. Caulfield, what do you think?
I would agree, and it's all about client choice. And you mentioned earlier, Dr. Hodgkins, that one size doesn't fit all. So for some, they really find this as a wonderful adjunct to their regular therapy sessions or their doctor visits, and others, just don't choose to utilize the tool. But it is an additional tool in their toolbox, and if it's working and providing help and support, additional help and support, we find that many of those apps are quite good and quite helpful.
Great. Thank you both. Next question is, ACOs only have a calendar year to produce total cost returns, or reductions rather. How long does it take to produce total cost savings once your program begins?
But certainly it depends upon the individual, but we know time is of the essence. And so when we are working with a client and doing that deep dive, determining what are the barriers to them being successful, and staying true to their treatment plan. When we discover what those issues are, then we quickly jump in and ensure that those additional supports are provided. So oftentimes it's a matter of weeks before you can start seeing cost savings. I think of one example of an individual that prior to coming into care coordination was Baker acted, going in and out of the crisis stabilization units, numerous times a month. And when it was then determined what the root causes were of that frequent visit, we got to work on making sure that other ancillary services were provided, and that recidivism rate into that CSU went down to nothing. So it doesn't take a year to see results. Oftentimes it's a matter of weeks, and you'll see a great reduction in those high-end, high-cost service delivery.
With our Project Save Lives program, there's been, from 2019, our fiscal year starts July 1st, so through 18, 19, 19, 20, we cared 28% reduction in emergency visits. So that's $1,000 and some odd each time JFRD picks them up, and $4,000 a time for an admit into the emergency room. So that is a cost savings, and the recidivism rate went down by 28%, even though opioid use has gone up during the COVID crisis. So, you can have a lot of emotional savings for the individual and a lot of financial savings for providers and the community at large.
Okay. Yeah, great. Next question here is, and this is a little bit of a longer question, so if you need me to repeat it, I can. It says, thank you for sharing your organization and partnership. This is an enormous problem with serious mental illness population, with the SMI population. The HIPAA issue was brought up. And this, in addition to a lack of resources in other communities and lack of knowledge among LE and HCP dealing with SMIs, places a major burden on family with no positive outcomes. How do we overcome the HIPAA issue for family trying to care for an SMI patient to avoid their illness deteriorating and becoming unreachable as homeless or incarcerated?
Oh, go ahead, Dr.
It's a lot.
Yes, and
I mean, it's an overwhelming problem that we deal with all the time.
Yeah.
Go ahead.
I was just going to say that as Dr. Hodgkins mentioned earlier, it's critical to get that consent signed. And if that individual is not under guardianship and they are of sound mind, if you will, to be able to sign it, it's important to have that motivational interviewing training to be able to better engage an individual that is in crisis or perhaps not, thinking as clearly as they could to sign that consent. If you need to find out if that individual indeed has, a power of attorney or a guardian that is responsible, and get them quickly engaged as well. I know Dr. Hodgkins has some comments as well.
It's just that this is a universal issue for healthcare providers, whether you're a hospital, a doctor, a nurse, behavioral health, physical health, and families especially, if they have mental health issues and substance use issues and they're adults and they don't sign a release, you can't let the family know. So think about how agonizing that is as a family not to know where your adult child is. Knowing that they have these issues and wondering, are they alive or are they dead? So I have very strong feelings about this, and really and truly it's where care coordination comes in. I can tell you just recently I had somebody call me and ask if we had a bed available for detox because their son needed treatment. And I said, you know, I'll look. We're at reduced capacity right now because of COVID. But and then he called and said, well, I haven't heard and I don't know where he is. And I went by Gateway and I didn't see his car. And can you tell me anything? I'm like, I can't tell you anything. I can't tell you. I can't confirm or deny that he's here. I mean, that's part of the HIPAA and 42 CFR. But behind the scenes, I could look to see his name. My peer coordinator, he was one of the people who had come into PSL. And so I had the peer work with him once he was released from being Baker active. And the peer worked with him and to the point where he came into detox and he signed a release and he could call his parents. But that was 5 days worth of agonizing for the parents. So, you know, one way to fix that down the road, and SAMHSA has been addressing that, is policy, changing policy. And the more BAAs you have with your partners in the community, the easier that is because you're not breaking HIPAA. It's a problem, but care coordination helps with that because you can do a lot behind the scenes. I mean, they didn't know what I was doing behind the scenes, and I wasn't breaking any HIPAA laws. I just said, is this somebody who's come through our PSL program? And he was. So I was able to say, okay, if you find him, if you see him, please work with him so that he can get into detox and see if you can convince him maybe that he can sign a release so we can talk to his parents, or he can talk to his parents, either way. So it takes a lot of work, but that's the beauty of care coordination.
Great. So we have time for one last question. There's actually the two that came in that were very similar, so I'll just ask both of those and you could probably answer them at the same time, and then we'll have to conclude. And the first is, what type of people do you hire as care coordinators? Do they have clinical backgrounds? And then the other one is similar. It says, what training or credentials do your peer coordinators receive or hold, and where do they receive this training?
Let you answer that, Dr.
Yes, so I'll address the peer training first. At LSF Health Systems, we have a very robust training institute, and we were able to apply for and receive a grant from HRSA because we, here in Florida, we realized the great asset that certified recovery peer specialists bring to the treatment milieu. And but the problem was that we didn't have a lot of them that were available for hire because the state had not begun to reimburse for those peer services. So when they did decide to reimburse, our providers were very anxious to hire peer specialists, but we didn't have enough to go around. So we received a grant. We trained peer specialists to be able to sit for their certification board. The course consists of 40 hours of training and then additional hours as electives, if you will. And then there's 500 hours that are required in the state of Florida to have on-site hands-on experience in working in the peer field, and then they're qualified to sit for certification. And so far we've been able to train over 230 individuals with lived experience that were eager to come into our network of care and work with our providers, and they're placed in all sorts of different treatment settings, emergency rooms, OBGYN offices, PCP offices, and so on. And a lot of them, for example, have their own passions. Some want to work with children, so we're able to place them in an organization that serves children and so on. So it's been tremendously successful.
Great, very good. And the second part of that question was the care coordinators and their clinical backgrounds.
care coordinators, our care coordinators have at least a bachelor's degree. Some of them have masters and are sitting to become licensed in the state of Florida. So it's a little higher level because they have more like of a supervisory, the way we use them, a supervisory component as for the other peers that work for us. We have almost, I don't know, 32 peers that now work for us because they're so beneficial. We hire them, they, you know, they're trained, and then they sit for we pay them while they're sitting for their 500 or 1,000 hours. There's 2 different ways you can get certified. So yeah, that's our care coordinators are more clinically professional and trained than the peer specialists, so to speak.
Great, great. Well, hey, unfortunately, we are out of time for questions. If you want to put yours in at the last moment, we did have a couple more. We'll make sure to get those answered via email afterwards. But I wanted to thank you both. Actually, all 3 of you. Jack, I know we couldn't really see you. I think he's on the. Oh, there he is. He's back. And he was on the road today, so we had some broadband issues. But you guys did a great job. It was very informative. I wanted to, as we close out here, wanted to encourage you all to visit the InfoMC exhibit booth at acoexhibithall.com and to learn more about them, connect there with their team. And you can learn more about their programs and what they're doing. And also the ACO Exhibit Hall is where the recording of today's session will be archived. So if you wanted to access that later, then you can do so there in the reference library under webinars. And there's a lot of other material there as well for you. And lastly, if you wanted to connect or would like to connect with Dr. Caulfield or InfoMC, Georgia Buck, they'll be happy to interact with you and to answer any of your questions. Their contact information is here on the slide, so feel free to make a note of that, and they'll follow up with you for further discussion. So thank you all so much for attending. I hope you found today's presentation very informative and helpful. I certainly did, and I hope you have a wonderful rest of your day. So thanks a lot for coming.